Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare. We're produced by Bright Spots Ventures. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, healthcare systems, and other healthcare organizations around the land. Our goal is to identify as many as these bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization, because we believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. So if you want access to some of the great ideas and insights shared by your peers and leaders in the industry, if you want to stand on the shoulders of giants, I encourage you to go to wherever you listen to your podcasts, Apple, Spotify, Amazon, wherever, type in Bright Spots in Healthcare, find the show, and subscribe so these episodes every week are downloaded to your device so you can access all that great information and you could be smarter at your organization. And if you're so inclined, you could leave a testimonial or a comment like this one. The effort of bringing healthcare professionals to a conversational call to discuss real-time challenges and successes in healthcare is a great format and allows for candid discussion of goals, objectives, and challenges that we are all moving through. Thank you. And that comes from Scott Schweiger, who's the vice president at the clinic at Cleveland Clinic. So we'd love for you to subscribe, comment. More of your peers could find the show that way, and we could all help each other in progressing healthcare in this country of ours. Today's topic is a great one, and it's actually one that was suggested to us a couple of times over the last 2 or 3 months through our feedback forum. That's going to be coming at 45 minutes past the hour for those of you attending live via Zoom right now. Ask you the favor of taking those 2 or 3 minutes to complete that survey. But our topic today is unexpected strategies that are closing gaps in Medicare and Medicaid, and that comes from the feedback you provide us so that we can be better and deliver value to you each and every hour we produce a show. So thank you in advance for completing that survey. And I am excited to talk about this topic. Our partner for today's episode is an organization called HealPros. And if you haven't heard of HealPros, I encourage you to check them out. Check them out at HealPros.com. That's HEAL pros, one word.com. They work with health plans to bring care anywhere. They make a difference in people's lives with chronic illnesses by actually traveling to their homes and helping these individuals access the care they need through a nationwide team of care access pros that are trained to improve the lives of each and every person they touch. I encourage you to check them out. And thanks again for supporting the show. Our all-star panel of guests today are going to bring you some great bright spots. I've met with each one of them individually. I'm excited for you to learn from all of them and benchmark off of all of their ideas. In any particular order, our guests are from the aforementioned HealPros, Michael Harris, the Chief Executive Officer there. We also are fortunate to have Teja Sweta Carve. She is one of the leaders in Medicare Stars quality improvement at Mass General Brigham Health Plan here in my home state of Massachusetts. We have Mike Raypatch, who is the Senior Vice President of Government Programs, as well as the President and CEO at CareFirst Community Health Plan in Maryland. And we have Daniel Weaver, the Senior Vice President of Stars and Quality at Zing Health. So thank you all for being here. Really appreciate it. And I want to start, before we get into the programs and the ideas and the bright spots, I want to start high level with a strategy question. I love starting at a very strategic level. I love hearing how organizations think about generating ideas and progressing innovation at their organizations. It's a struggle at health plans. We know that. And so, Mike Raypatch, I want to bring you in first. How is CareFirst intentionally fostering a culture of innovation, and maybe walk us through how ideas are surfaced, how they're piloted, and then either scaled or sunset?
Excellent. Happy to, Eric. Thanks for having us on. So from our perspective, we start from the premise that we don't quite know everything that's going on with the members that people are trying to support in the community. And that the idea that what happens with them in 15 minutes in a provider's office is going to change their health. Everything else going on is going to change their health. It's going to have an impact in their lives. So we have a lot of vendors that we bring in. We talk to them, we understand, we analyze, and then we figure out how to pilot. We figure out how to try something, modest dollars, modest commitment, modest scope, but enough to get some data, to get some information, and to get some feedback. And it's really built around that. Let's get some feedback and see what the members say, how the community reacts, where is the impact of this. I often am saying in the meetings we're having, give me something I can say yes to, because we're obviously not meeting this metric. We're obviously not driving this thing. We have some cost of care challenges. So let's put some things out in the field. Let's learn. And it's really about building a learning culture, about building an idea that we don't have to have a perfect ROI. We don't have to start with the wonderful business plan that's so complex that nobody will ever be able to execute it. We're going to try some things and we're going to learn. We're going to adjust. We're going to see how the vendor performs, how we perform with them. We'll try to make some mistakes. We'll try to see how we can grow with this quickly and see how it evolves. But it's really built around this idea of we don't have a good understanding of everything that our members are going through each day, and their lives are complicated and individual and nuanced. And so we have to figure out programs we put into urban areas, to rural areas, into the DC suburbs, into Baltimore, kind of all these places where we have a wide variety of things going on, and then see what happens and see what we learn, tweak them, adjust them, and that'll help us select better solutions, better partners, better programs going forward.
I love that. I'm going to summarize a few of the things I wrote down here. Give me something I could say yes to is how you open there. You're creating a learning culture by bringing people in the same room. We're talking about making quick decisions, piloting something, figuring out if it can be scaled and if it cannot, and just making a very quick decision on it. I took a bunch of notes there. So incidentally, folks, if call this an incentive, call it a bribe, whatever. But if you take that feedback form that we're going to send you at 45 minutes past the hour and you're attending live, I will send you a copy of my unabridged notes. I'm not telling you they're professionally written, but I take a lot of notes and they're pretty darn good. So if you want a sort of summary, better than the transcript, incidentally. So if you want a summary of these notes, give me 2 or 3 minutes with some feedback at the end. Thanks. All right. So I love that. And I think it's a great setup, Mike. And I'm going to bring in now Michael Harris, and he's the CEO of HealPros. Michael, as health plans are thinking about now those real hard to reach complex MA members, let's say they haven't seen a PCP in years, accessing them and re-engaging them is super hard. So could you share maybe an example of how a health plan is doing something different, or maybe even doing something grassroots that is just, re-engaging these folks and getting them healthier?
Yeah, I think you used a good term, right? Hard to reach. I think we maybe toss around, and it's the technical term of non-compliant. But that really kind of puts the onus on the members, whereas these members have real and perceived barriers to access and care that's on all of us to overcome. And so difficult to reach isn't just about rural populations, which it is, but you also have small towns, micropolitan areas that may be difficult to get to, are underserved communities. And then you see just as much in the urban communities as well. They're just facing different challenges, right? Might be healthcare literacy, might be distrust with the healthcare ecosystem. There are dangerous neighborhoods. People don't feel comfortable. There's cultural disconnects. So one approach is, instead of getting these members, convincing them to go to the ophthalmologist, to the eye doctor, is to visit these members cost effectively at scale, in thousands of homes across the country. You want to find people that are empathetic, that are driven to care for other people, and people that are from the communities or from similar communities as the ones that they're serving. And so worked with one health plan that used this approach. They started early in the year. They were very transparent about what their goals needed to be. And for the first time, got all of their contracts in the North Carolina market to 4 and 5 stars for the year. So, it's difficult, but it can be done.
What were they trying to do? What were they very specific about? Who were they targeting?
So this was the underserved population, right? So they had a good idea from past years of who was going to engage with the clinicians, and kind of went with the assumption that everybody else wouldn't. And so that was the target population that they knew they needed to get to in order to reach their goals.
And Michael, what specifically were they trying to do with those individuals once they got in their home? Was there a particular, were they addressing loneliness? Were they trying to come in and do an in-house assessment? Like, what was the purpose of the knock on the door there?
Yeah, so this was primarily for diabetic eye screenings.
Okay.
These members may have had multiple open gaps that were addressed at the time, but the primary driver into the home was the diabetic eye screening.
Okay, we're going to get into later because you said like getting in the home and at scale at the same time, and those seem to be a little bit at odds ends there. And I'd like to kind of address that in a moment. But and I also want to be clear: these are not community health workers you're putting in the home.
Correct. It can be community health workers, they can be RNs, but really it's anybody from the community that we bring in-house, we train to do these different services. Again, looking for empathetic people that understand the situations that they're going into and are willing to help.
Got it. And Teja Sweeta Carvey is in Boston, Mass General Brigham Health Plan, leading Medicare Stars and Quality. So when we're talking about Medicare and Stars, and we're talking about Boston, where there's all different areas around here that have scary to go to, hard to reach, maybe even though there's all these hospitals, probably not great access or trust. Are you taking, like, how do you think about this approach?
Yep, that's a great question, Eric. And exactly, it's metropolitan area, hard to reach, but sometimes they can reach, but they can go to different places. And even with Mass General Brigham, you see this nationwide, any bigger health system, diabetes eye exams specifically, cameras. You require a camera for that. Not all primary care offices have cameras, whatever their name might be. So, but they do go and get their eyeglasses. So we are assessing with our supplemental vision vendor here for Medicare Advantage. Can they do that same time? Get their glasses, contacts, and also that diabetes eye exam at the same place and close the gap in care. Because that would be a great way, getting members the service where they are at. So that's an approach we are certainly interested in. Yeah.
Okay. It's not like you guys prep together either. So it's both similar. Incidentally, folks, if you want to co-moderate with me, we do have a packed agenda. You have a Q&A module there at the bottom of the screen. We already have a question. You know what? I'll ask it to you, Michael, and then Teja Sweeta, I don't know. Do you use what kind of machine do you use for the diabetic eye exams? And are you able to conduct an ROI, in particular for this North Carolina plan?
Yeah, so we just recently switched over to the Remedio cameras. And we've been using those with some good success over the last year, but we've used other brands in the past. There's a lot of good camera manufacturers out there. So this is just, kind of where we've chosen to hitch our wagon. I'll say this around the ROI. For the 2024 star ratings, if you didn't get at least 3 stars in the eye exam measure, you only had a 3% chance of hitting 4 or 5 stars overall. So, that math is going to look very different for every health plan, but I think that's a key to, it's not just the eye exam that's happening when you're in the home, but this speaks to the CAPS measures.
Don't go there yet. Don't go there yet. All right. Well, hold on. I want to hold on. We got some good stuff around that. All right. Yes, I love that, and that's just fascinating. So, just to repeat that stat you just threw out there, if you are not getting a 3 or above on the diabetic eye exam, there's a 3% chance you're going to hit 4 stars, according to the 2024 data. Is that
correct? Yeah.
Awesome. Okay. All right. I'm gonna shift gears for a second, and let's talk about value-based care and benefit design and how that drives partnership strategies. Sort of when you heard at the very beginning, when we were talking to Mike Raypatch about strategy and bringing vendors in and looking at things and feeling first. Now let's progress to benefit design and partnership strategies and driving meaningful improvement and closing gaps of care. So I'm going to bring in Daniel Weaver, who is the big cheese when it comes to stars and quality at Saying Health. And Daniel, how are you guys driving meaningful improvements in closing those gaps for these hard to reach members, layering in value-based care and benefit design strategies into your partnerships? Maybe you could share, how you're doing this, how you're customizing these strategies.
Yeah, sure. I mean, there's a million cliches out there. Put the member at the center of what you do, member first, member centric. But at the end of the day, that is really how it starts. Zing's entire, design is based around really trying to ensure that we've got a comprehensive solution for the members that we're trying to serve. So whether that's how we select the value-based partners and what those contracts look like, how exactly we're designing the products to make sure that the very specific, whether it's the supplemental benefits, the Part D design, the access to certain providers and facilities, specialty care, whatever, that those things are really geared toward the people we're trying to serve. And then the engagement model that we have wrapped up front to try and bring all those things together. So in a nutshell, we've got about almost 100% of our membership in a value-based contract type of relationship, whether that's at the PCP level with really strategic partnerships in those communities where the people are at, so that they're seeing docs from their communities, people they trust, people they got relationships with, or whether it's the, sort of third party types of relationships that help coordinate that care across the spectrum. That's really one of the key things. The second part I'd argue is how you design that benefit. So you got to work with those value-based partners. If we're just putting a benefit on a market that doesn't really align with those value-based partners' objectives and we're not setting them up to be successful, it doesn't really work either way. So they're involved at the table as a part of the everything to the bid design, customizing supplemental benefits, the whole thing. At least to provide feedback. We've ultimately got to make the best decisions, for what we believe our membership needs. And then the last thing I'd say is it's probably kind of a micro focus on those conditions, right? You truly have to understand we're CSNP focused plan model. So we're really trying to hone in on designs and partners that can really target those things in the communities and the membership that we're serving. So partners that are aligned to the specialty types of care or really truly specialize in driving results within individual types of conditions, diabetes, cardiovascular types of things. Those are really what help us connect all of those dots together to make sure that the full suite, the people, the processes, and the actual products are all working together toward the same goal.
That is great. And so every single contract now you're putting into place has some sort of risk share with every one of your partners.
Call it almost 100%. Yeah. We've got every member that is within our spectrum is covered by some type of a value-based relationship so that someone is taking risk to help manage that member. So some of that, call it half of it plus, is at the PCP level. And then the rest of it is layered on based on the special needs that they have, whether it's, again, diabetes focused or cardiovascular focused. We have ESRD products. So we're really trying to find the right partners, the right solutions that are going to specialize in helping those people connect all the dots across the continuum.
That's, I was going to actually ask my last follow-up for you before I take you off the hot seat here is how you're approaching using the layered strategy to connect the dots and how you're connecting the dots. And when you're saying connecting the dots, my guess is between the different touch point solutions and some of the operations that you guys have in touching the member. And I'm just curious if there's an overall methodology to that or if it's these contracts all aligning you.
So a lot of that happens at the point of, sort of onboarding with the members. We're aligning them to a product right off the bat that is either tied to one type of a value-based partner or another. And then during their initial, 45, 60-day onboarding process, we're making sure that they're getting connected to one of those partners that are going to best serve their needs. So we have a high early engagement model type of product and process setup. And then, of course, we're doing all the things on the back end, right? We're sharing the data across partners, trying to play that coordinator of care. We've got processes internally to make sure that the stuff coming back from those partners is getting into all the right people's hands here. So whether it's an inbound conversation, where somebody's just asking a question about a product that's flagging and saying, hey, I need to get this person set up with this partner, or hey, they selected a product that is a narrow network, PCP sort of tied product, but they haven't seen them yet. Let's get them in there. Those things are all really folded in right at the get-go to make sure that that person doesn't just sort of languish in obscurity once they've joined. We really want to get them engaged and get them into the right paths, because that's how you can long-term really make an impact on those care gaps.
Got it. It's great. Navigation is such an important part. We're always talking about navigation. I think it's easy to talk about it. It's hard to execute. We'll talk more about it later, but that seems like the key to all of this working is the navigation and then picking the right partners. Incidentally, folks, I know we're basically CMS audit season is here basically. And I know we're all waiting for the April 7th final rule on Medicare Part C and Part D and all that. So we're definitely kind of scheduling out our programming, within our sweet spot of sort of value-based care strategy around Medicare, Medicaid. And so we have a couple of upcoming episodes I wanted to tell you guys about. If you're listening to the podcast, you can go to brightspotsinhealthcare.com or look at the show notes of the show you're listening to register. If you're attending live, we're going to help you out. If you want it, we're April 3rd next week. We're having a panel together to talk about complex and hard to reach Medicare members amidst all the CMS uncertainty. So a similar but different angle to today's topic. And if you want to join us from 12 to 1 live next week, we'll register you. We're going to put a poll up right now. We'll just register you. So let us know. We'll also have another episode on April 17th with more of a provider bent to it around the new physician playbook and how AI and workflows and value-based care are being put into action to hit all of the different requirements you need to close gaps in care. So if you want to go to one or both of those episodes, we'll register you. I know there's a gap there. I'm going to talk about April 10th, the week of the gap, in a moment. But if you want to come, we're putting a poll up live. Mike Graypatch, I want to come back to you and talk about medication adherence and obviously Part D is a beast, and anyone that's dealing with hard to reach members, we know that medication adherence is one of the big things that drives all the bad things if we don't get it right. So what's kind of dovetailing off your answer around innovation and what you guys are doing around innovation at Care First, what are some unconventional strategies, or maybe one that you could share that Care First has used to actually move the needle around med adherence?
Absolutely. So we've been working with a local partner out of Baltimore here, Scene Health, and they've been working with us for about 3 to 4 years in terms of medication adherence through asynchronous technologies. We found that, especially in our Medicaid population, people would get medications, they wouldn't understand them, they wouldn't know why they're there. They would kid get an asthma inhaler and wouldn't be explained how to use it properly, so it actually helped them avoid going to the emergency room. So they do a lot of training for us and help those members and engage with them. And then there's the constant checking in. So the member records a video of them taking the medication each day. And then somebody replies back with a video saying, hey, great job. Thanks for doing that. Looks really good. Try this, do this a little bit differently. How's everything else? And you're not trying to get everybody to sync up timelines. You're creating a way where they can communicate and talk to each other, but yet kind of on their own schedules. The real key to medications for us is, STARS measures are there, metrics are there. We're expected to hit those in both Medicaid and Medicare. But what we've seen is that through this mechanism, we're seeing improvements in acute visits. We're seeing reductions in hospital admissions. We've got some data right now that says we're about 5% less hospital admissions for this population, as opposed to about a 15% increase for the population they're not working with. And so for us, that's serious money. And hospital admissions and acute visits and those types of things are the key thing we're trying to avoid. We want people to go to primary care. We want them to take their meds. We want them to maintain their conditions. Getting them out of the hospital and keeping them out of the hospital. And that's kind of the holy grail in this business in many ways, because that's where things get expensive. That's where they get exposed to new issues. That's where they get sicker. And I'd rather have them at home and treat them there and keep them comfortable and keep them happy than having them in any of our hospitals and having to just manage the complexity of that entire situation.
All right. So video asynchronously using a mobile phone or an iPad or a tablet, we should call it, to be non-brand. Okay.
Yeah, we had one member who reduced his A1C from 12 to 5.5, lost 80 pounds, got a dog, walking, involved in his community, all because this program helped him just stay on his medications and get active and start changing his life.
It's massive. That's awesome. That's awesome. And did that come out of that sort of incubator model that you talked about? Not the innovation model, I should say.
It did. We knew we had adherence problems and we were looking for some partners, and luckily one of them was local. So we could sit down with them in a room and say, how should this work? And we could monitor, we could go see what they were doing. We could be part of the discussion. And it really helped us evolve and understand how to do this a little bit better.
Great. Thanks for sharing that. Folks, again, if you want to help me co-moderate, Q&A module at the bottom of your Zoom screen. You should probably know that by now, but Jess will, our producer will be looking at those and submitting to them. Don't use the chat for the questions, though. Use the Q&A. We've been doing this show now for over 11 years. It's been a privilege. It's awesome. We're going to continue doing more of them, and we get to do more of them because we have incredible support from innovative companies from all over the world, actually. And I mentioned HealPros is supporting this show. I want to tell you a little bit more about them very quickly. They are working and helping health plans find and address missed care opportunities like diabetic eye exams in the homes of your members, at events in their communities and anywhere else. And their team just specializes, especially, and we're going to talk about it in a little while, polychronic members getting access to all the care they need from anywhere. They use Care Access Pros. These Care Access Pros have been in over 70,000 homes in 2024 alone, and they're just committed to engaging and getting to know your members, getting to know their situation, not just their healthcare situation, and helping them get the right care, not just that diabetic eye exam in all these hard to reach neighborhoods and areas that you're trying to serve so that you could achieve your maximum bonuses from CMS and just doing the right thing for the individuals you're trying to take care of. They make these CAPs, as they call them internally, these Care Access Pros, make over 4 million calls to members each year. So, it doesn't sound scalable, but that sounds pretty scalable. And they've got sophisticated logistic operations, a national footprint from all throughout the continental U.S. and beyond. They work in all 50 states, U.S. Virgin Islands. That's where the beyond comes from. And so if you want to check them out, HealPros.com to learn more about how they are making the human touch scalable. I want to now switch gears and talk about, it's not really switching gears, but I want to get into, Mike at the very beginning talked strategy. I talked strategy around how I believe finding a bright spot and cloning it is the way everyone should be thinking and learning. It's really called The Power of Positive Deviance. And there's a book on that. Jerry Sternan's really the founder or the godfather of it. Tejaswita Karve at Mass General Brigham. I want to talk about how maybe at Mass General Brigham, you're not talking bright spot in the way maybe I do, but what's an example of how maybe your organization is looking at things that are working well in different lines of business? You see them, figure out, can that be scaled to other lines of business like your neck of the woods in government, and cloning those and just creating a new process that works to access hard to reach members?
Great question, Eric. Yep. So the answer I'm going to give you is probably something very familiar, but most often forgotten, but is the gateway to the health plan: customer service, right? We know customer service is that mile marker in the entire member journey, from enrollment. Most of the enrollment in the senior market, where Medicare Advantage, where my focus is through those call center lines and all the way to disenrollment, even everything in between, from understanding benefits, EOBs, you name it. So that's the customer service piece, and especially in senior market, even in Boston area, Eric, since you brought up, right, any metropolitan area where you have more savvy agents, and we do see that in this area, but customer service still serves that gateway. And why do I say that is a bright spot, right? So a little bit about Mass General Brigham. You know this, but just for everybody's benefit, when I say Mass General Brigham, people think of world-class healthcare system, which it is, but we are on the health plan end, right? So a truly integrated delivery system. And we primarily our roots are in Medicaid and commercial. So Medicare Advantage was launched only 2 years ago, and we're growing super fast. And the reason I brought up Medicare and commercial is that's what we're known in this area particularly. And for commercial, 2 years in a row, our commercial markets have won JD Power #1 award for customer service. So that's our bright spot. And we do talk about ROIs, right? Numbers. Most 4+ star plans, if not all, they generally tend to have customer service in-house. Because these are the people the organization is invested in. That means they're going to give better service to our members. Not a lot of new plans do, especially in Medicare space, launch customer service in-house because it's a huge lift. But in our case, we actually do have customer service. We are not even completing 2 years and 3 months. 90% of our customer service in-house. That comes from our commercial experience, where that really drove customer satisfaction and growth for us. But in Medicare space, it's a little bit more challenging, right? It's highly regulated space. So we had to think through this. We had to look into investments, starting with technology, tools, policies, procedures, because everything is a part of the program audit. Then we had to look into bringing more experienced agents. Medicare is probably the most complicated customer service, the questions you get from seniors. So our customer service leader actually made sure we were getting experienced hires, and especially from local market, because markets are different. So getting them on board. And she also invested very heavily in this organization. We have invested very heavily into training, forward-looking training. And maybe later in this conversation, we'll bring this forward-looking training back again, but really having a solid knowledge base. And when we talk about tools and technology, we're also talking just not the robust tools and technology, but even evaluating how can we use AI. That's something that Mass General has really focused on, is broadly digital aspect of it. So which also we can talk later on, talk about experience, but customer service is a great use case for applying that digital experience for us. And apart from building that capacity, I think having customer service in-house, and it's a bright spot for us as we talk about gap closure, is MA is very cyclic, right? So we have Q4 and Q1 when there are enrollments going on. That area is very busy assessing members and getting them enrolled and addressing those things. But in Q2 and Q3, when they do have that scaled up capacity, when they do have time, they are now going to be focusing on that gap closure, talking about connecting members with the services, including even how can we get them to those eye exams that we started. But that's where having that in-house customer service is a huge, huge advantage and a bright spot, something we're good at and we know we can do it, and pretty confident. We are very hopeful that customer service effort, time, and investment we have done in the last 15+ months is going to bear fruit in upcoming star rating. So that's a great bright spot. You're on mute, Eric. Sorry.
Yeah, I was getting background noise causing it. At least I was accused by my producer. So I put on mute. So it sounds like we all need to be checking out what the commercial folks are doing well. Let's not worry about what they're not doing well on. I'm sure there's a few things they're not doing well, and take what they're doing well, figure out, can we apply that? Have we applied it already? And if we haven't, can we? And in this instance, bring customer service in-house. I like that a lot. Before we go on to our next question, there was that gap when we asked you if you wanted to come to April 3rd and April 17th episodes, because on April 10th, I'm piloting something. One of the things I'm trying to do is for your leadership is to provide more concise executive briefs and lessons that we're capturing from all the different conversations and interactions we get to have. And so recently I had the good fortune of being in the same room to listen for about an hour and a half to Michael Lewis, who is a well-known author of books that have become movies like The Big Short, and Moneyball, and Blindside. And he talked about sort of storytelling and leadership lessons. And so I created a 15-minute episode we're putting the final touches on leadership lessons from Michael Lewis. That is a sort of a C-suite like kind of series that we're calling Executive Brief for now. Maybe I'll come up with a better name later, so don't hold me to keeping that. But if you want to, before we drop it, get a kind of preview of that and be able to give me some feedback before we post it live, let me know through this poll, and we'll get you a link to a copy of it to give us some feedback. It's audio only, and we'd love your feedback, and you could get it before it drops on April 10th. All right. Michael Kira, so I want to bring you back in because when you sort of started going in this direction, and I want to go there now. When we're talking about complex polychronic members and the obvious advantages of being in their home, how can something like the diabetic retinal scan that we've been talking about open the door to a health plan's overall whole person care strategy, and maybe take us through how a health plan is building upon that in a way that's helping their business and helping the members they serve?
Yeah, so I think if we go back to the statistic about the returns that you get from just being 3 stars in this measure alone, start thinking about the downstream effects of having somebody in the home, right? There's, of course, the other gaps that you can close while you're there. Maybe it's a A1C test or bone density screening, something to that effect. But you've also taken an action to build trust with the member, both from the health plan standpoint, as well as the person that's actually interacting with the member. And so that can just carry on, that has a trailing effect on how the member engages with their care. Because the ROI on that can be so big, that kind of drives the visit into the home and really takes the cost factor out of closing these other gaps, if you will. And it's not just, one polychronic member in one home. We've done, like you said, we've been to the Virgin Islands. So that was taking a whole group that is typically underserved by most standards. We got a team together, did some cultural assessments and training for them to go down there. And then we saw several hundred people in the span of 3 to 4 days close several hundred gaps that would not have been closed had this action not been taken by the health plan. And you had this group of people that was open to it, that wanted the care. A lot of times they would have to travel back to the States to get it. So you're not only closing the gaps, you're creating a great member experience for these people that are in a typically underserved population.
So we're talking about, I just want to get a size. So obviously Virgin Islands are isolated by its nature. We're talking about how big was the market? How many people were you targeting? Just to get a sense that we could kind of, I'm trying to create sort of an analogy for everyone. If they were dealing with the rural market, let's say in Oklahoma or an urban market somewhere, but just hard to reach members. I'm trying to get a sense of what you could do here.
Yeah. So, and this could be true for any rural market or any market that is in need, but they had about 800 people that were interested in receiving this service. And ultimately about 400 came through and received the service. So 50% conversion rate on, what they considered was their top line goal. So a very small population in a hard to get to area was very successful for them.
And we weren't in this case, we were still doing the diabetic eye exam, but we were also focusing on folks that needed blood pressure, bone density, A1C, and all of that.
Yes. Yeah, absolutely. Anything that we could do.
Great. Incidentally, folks, we're working with Michael's marketing team on editing with them a blueprint called 4 Strategies to Reach Hard to Reach members and Boost Stars Performance. and it's almost done. So it'll probably be done by next week, early next week. So if you want a copy of that, I've had a look at it. It's very concise. It's a page and a half, but it gives you a really nice blueprint with some data to support it. It will have some HealPros branding on it, deservingly so, because a lot of the data we're using is from them. But Jessica and I have had our fingers all over it to make sure that it's reading well for you guys. And if you want a copy of that, we'll send it to you. Let us know. We can put that poll up, Jess, and we'll just send it out to folks. Daniel, expanding upon your benefit design theme, how are incentives being used by you guys? And, obviously incentives work sometimes, but you need to tie it to the right thing at the right time. So how are you guys using benefit linked incentives to drive action? And what are you seeing as far as results?
To play off a cliche, you have to have all of the stars aligned. It kind of reverts almost back to our previous comments, right? So we have an incentive program, sure, but we've also tied incentives into our actual product design. And I would argue the simplest answer to your question is making sure that those incentives, the things you're targeting, as well as what those rewards are aligned to your benefit design, as well as your provider partnerships. So simplified our programs. But we also reduced what you'd market as an incentive program to tie some of the incentives back into actual products. That helped us push forward some of the engagements that really help drive the preventive care and are going to help us ultimately with gap closure. We aligned those activities to our value-based partners incentives as well. So making sure that we're incentivizing the same activities, but in a way that's going to drive membership to engage with those value-based partners and ensure that they're maximizing the, efficacy of those models. And then you pick something unique, like, we tied actual funding of a food benefit, a food allowance, to completion of early preventive care actions. So we tied them into completing an HRA within the first 60 days to be able to fund that particular benefit then for the rest of the year. So those types of things have helped us really get an early picture and drive early engagement with the members. We want to talk outcomes because obviously that's the ultimate goal, right? So, we're trying to boost STAR's performance with these measures. If you go back and look at Zing's history, you can look back 2 years and weren't so good, got a little bit better last year, and the plan is to obviously just keep getting better. We've seen early improvements already this year in first quarter engagement rates are up like 20%, reduction, like almost a 50% reduction in our early disenrollment rates for members that were like opting out quickly versus previous year. We've seen early lifts in our preventive care screenings from these types of activities and this type of engagement up front. Pick on the simple ones like the colos and the breast cancers. I mean, our rates starting off this calendar year are better than where our HEDIS rates were started off as we came into this HEDIS season for our prior year. So we're seeing the early results of really trying to enrich that reason for the members to pick a plan that we know is going to help drive and address their needs. But we're also making sure that those activities that we're asking of them to do also align to those needs. If we've got a diabetic coming in that's looking for a specialized diabetic plan, it doesn't make as much sense for us to incentivize them for the 5 other things that are going to really help them address their core problems. Once those things are addressed, I think it was Mike that said earlier, it's the things that happen at home, it's the everything else that's really driving whether someone's going to get the care they need. These things are designed to take some of those burdens away so they're not worried about these things and they can focus on all of those other things.
Okay, so you said a lot there. I want to unpack it real quick and make sure I capture it all. Besides, I'm taking notes, and those notes go out to everyone who's going to complete that survey. It's going to land in your inbox in 2 minutes. So, Daniel, sorry. We have the main impact here that you're able to generate through the engagement is navigation, right? You're able to get these folks participating and then point them in the right direction. You're also reducing maybe the mental noise, the noise that they have to deal with in their life. You're reducing some sort of headwinds for them. And what I heard you say is this program, although we weren't talking dollars and cents per se, we could do some just generic math on what this could mean. You got a 25% increase in engagement. Did I hear you right? A 50% drop in attrition?
Of our early disenrollment rates, yeah. So last year, let's just say we were running 25%. I mean, we're, down close to 10% already this year. It's cut in half from where it was the previous year.
And then this is the one I want. That's awesome. And then the one that I'm just not sure I'm understanding because it seems so profound. are the screening numbers this year already better than last year, or could you just?
Yes.
That's what you said. Wow.
Yes.
Wow.
And obviously, some of those have carryovers, like a breast cancer screening is an easy one. You get one year, you don't have to get it the next year. So you build off of some of that. But early engagement, I mean, think we're almost 90 days in now, just that ability to get that coordinated relationship established early on, get these folks utilizing, get them engaged with the right partners that are flagging the things that are important. We're seeing the downstream implications of the other types of preventive care that they should have been taken care of. We're just getting better results. We're getting better engagement. And you've got better provider participation as well because it's aligned to their value-based models.
And it's got a very local flavor to it, to play on a pun with the food allowance, right? I mean, I want to stick with the local kind of the local theme for a moment here and go to Mike Raypatch. Mike, at Care First, how are you kind of innovating around local as a strategy, and maybe provide some examples of some things that seem to be working for you guys?
Yeah, good question. One of the things that came out of the pandemic is that people stopped talking to each other. And we've seen some data that says, loneliness is just as bad as not exercising in terms of what the impacts of your health and everything else you do. So we've been looking for partners, to Michael's point earlier, that are in the community, are trusted by each other. They're people that they know that can help drive engagement in someone's own care, get them to care about their health, their needs, and try to bring them into the community. We had one early on, unfortunately didn't get through the funding world, but was engaged in barbershops in Black communities and having barbers and people there talking while they're in the chair, talking about their health. You get your blood pressure checked, you've been to a doctor, how are you doing? Great concept. We had 75% engagement when they did outreach to people in the community because they knew them. And when they showed up at their door, they said, "Hey, I know you." And they listened. We have a couple others we're working with right now, and they're getting groups of people together to just talk about their needs, whether it's expectant mothers or people with diabetes or just people in the community. And you don't start off with let us talk to you about your gaps in care. You start off with how you doing? How's life? What's going on? Let's, do an event. Let's partner together. Or we have another partner in laundromats who are meeting our members when they're there, and they pay for a load of laundry. And then they talk to them about, do you have all the benefits you need from your Medicaid side? Are you getting to the doctor? Your kids go to 2 different PCPs. Do you understand how this program works? And just guiding them through and building trust. Now, I think it's the trust, it's the community, it's the face-to-face, it's, getting off of these things and just talking to people and starting to build that sense of you're not in this by yourself, and there are people here to help, and especially conveying that the health plan is here to help. We are paid to help our members be healthy. We're not paid to just, watch them go to the hospital. And so the more we can build that trust, the more we can leverage our partners to build that trust and get that positive outreach in the community. My Medicaid plan right now is running at 97% retention because we're seeing the real impact of living the brand that we promise, delivering on it, and having that outreach and partnership in the community for us overall.
But I don't know if I got the quote right. Tell me if I got it right. I'm good for a good quote, Mike. We are paid to help our members be healthy. That wasn't it, but it was close, right?
It's close. Yeah. Yeah. We're paid to keep them out of the hospital. We're paid to help them be healthy. We want them to have a good life. We're not paid to, just send them from one doctor to the next. That's what we need to do.
Yeah, I love what you said there. And, I know I'm a little getting on my soapbox again here, but, just talking to everyone right now, like, when we're thinking about, bright spots in our industry and how to really leverage the concept of positive deviance at our organizations, I don't think, when you're talking about barbershops that seem to be really working and other kind of local peer-to-peer like programs that, the CEO at a significant Blues community health plan is talking about, I would suggest that, look to like something as simple and right in front of you as Alcoholics Anonymous and how that program has stood the test of time. And there's no more difficult chronic illness, right, to deal with than substance abuse. And what keeps that program, in my humble opinion, going and effective is the peer-to-peer support component of it. So like, what else can we be doing as organizations across the land, or at least across the audience we're talking to you right now, to leverage the population to help each other? I think there's ways to do it, like some of the examples that Mike just gave you and some of the things that you're hearing today. But just a little plug for finding those little bright spots that are working on our industry and figuring out how to amplify it, because there is a lot of good going on here. Speaking of good, I want to get into one specific personal story, because as Mike teed up very nicely, almost like I had him practice. We're paid to help our members be healthy. I want to bring in Michael Harris to talk about maybe a member example that inspired you and that moved you, and how what we're trying to do at a local level could truly change an individual human being's life, and in doing so, if scaled, improve your business, which is, I know, what we're all paid to do, right? So, Michael Harris, why don't you bring us into a personal or a consumer story, we'll call it.
Yeah, we get stories every day. I think maybe one of the favorites across the organization happened in Los Angeles, so not a rural area, with a member that was living in an RV, essentially on the side of the road. So, no permanent address, but still very difficult to reach. We get there, and our Care Access Pro learns that, dealing with medication issues, anxiety issues, and food insecurity, right? Doesn't have food. Member opened up very quickly about that stuff on our arrival. So in addition to the things that we were there to do, like the eye exam or an A1C kit, our Care Access Pro was able to connect him to some state-based organizations to help him with some of the issues and connect them back to the health plan to solve the food insecurity problem.
And this was an RV home, right? This was not like an apartment. This was like an RV, right?
Yes, like a camper. Yeah. And so we do all that. We connect them. A couple days later, the member calls our Care Access Pro back saying, "Hey, I haven't received the food yet." And so our Care Access Pro runs to a grocery store. I think he grabs like a rotisserie chicken or something, brings it back to the member, and he sits and eats with him. And while he's there is actually when the diabetic food packages are delivered. And so I think it was a great story of, the plan came through for the member. The member, trusted our Care Access Pro quickly and enough to call them back as a primary point of contact to say, "Hey, I still need help." And we were able to get him the help that he needed.
Yeah, really cool. Love it. Staying with local and the power of community, Dennis, let's bring you back in. How in the era of AI and tech are you thinking about, the old school initiatives of just knocking on doors or just, shaking hands and kissing babies, so to speak? How is thinking about your local strategy? And can you share maybe some results?
I've been trying to find a way to knock on doors since I got here, but it just doesn't work. No, it's a great question. I would say that, community is definitely key. I will mirror everything that I've heard from everybody else here. Some of the initiatives that we've seen that I think are leading to some of these positive successes are, we've got a community focus for new member orientation, new member engagement. So beyond, past their sales cycle, it's really how do you get those folks, to engage with you early. We've taken the events out into their communities. So we'll establish very simple, it's not a town hall. I mean, it's truly a meet and greet where we'll make sure that we can walk through their benefits, that they understand what they have access to, that we connect them to those resources that can help them complete that HRA and get their food benefit. They can answer a question they have with changing doctors or, hey, making sure their medications are covered. For whatever reason, they don't want to call customer service, or maybe they have called customer service, but they just really want to be able to sit down and put it in front of somebody and work with them. That's made a massive impact, I think, in terms of the receptivity in those markets. And it's helped push word of mouth to build that trust. Because I think the core of all of these things in these communities is you really have to establish that trust with people. We've grown that into mobile mammography programs. Some of the provider partners, those value-based partners that we work with, have mobile mammography solutions within our communities to be able to get out. And we service everything from the most urban to the most suburban parts of the states that we're in. So, really understanding which solutions are going to work in which parts of the market, and then supplementing them. It's just trying to find ways to innovate on the old school models of at-home care. There's definitely a million different solutions that you can use to get care into communities and into people's homes. It's trying to find ways to make those more engaging, to make them more appealing to the members, to do something unique while we're there, close extra gaps, do better documentation, have a path to do follow-up with the members once it's done. Tie that back into, the meal programs, making sure they're signed up, they get that food access. Really trying to follow that full gamut to make sure that we can drive the results. And, for the results I mentioned earlier, I think a lot of those tie back into that as well, as opposed to just the incentives that we're doing.
So the juice has been worth the squeeze, even though these aren't necessarily super sexy technology-enabled initiatives.
Yeah, I think that's fair. I mean, we are embracing AI for other elements. We can actually facilitate that HRA that we talked about early on with members through an AI technology. So it simplifies the process for them. They're not stuck waiting in some crazy queue or waiting for, their name to pop up on an outbound campaign. So you think about scalability, right? AI is a great place to use scalability if the process is simplified enough. So that you're not creating a demand, supply and demand need for your members. But yeah, we use it for that kind of thing, as well as helping support scheduling and some of the other, activities that would just be sort of basics, blocking, tackling for people. It may not be sexy, but it's a way to be more efficient, more effective, and make sure that you're getting to members as quickly as they need you to get to them.
Yeah, and those are often the levers that actually change the whole course of that individual's healthcare journey. So the two things I heard there that you're getting out of this is better facilitation of completing the HRA and or scheduling, navigating an individual to their next step on their journey.
I think that's very fair.
All right, well, staying with digital, since you opened the door there, because we went from local to digital, so we'll end here. I'll bring in Tejaswita. In Boston at Mass General Brigham Health Plan, Tejaswita, how are you guys thinking about digital as a way to close gaps?
Yeah. So that's a great question, right? Digital. This is huge. Two ways to get in touch with your members. One is good older members to get in touch with helpline customer service and digital platforms. You're seeing rise of investment in digital, even at nationals. So certainly in our case, it is a big bet for us. And what do I mean? It starts with how do we know even that our members want to engage digitally? First and foremost, emails, right? Sounds very simple, but we have over 50% in such a short amount of time, or 50% of our member email addresses. And what does that translate us to when it comes to engagement digitally? CAPS, member experience survey, right? Last year was the first year when CMS allowed emails to be used for gathering the CAPS survey response. And 30% of our response rate came from emails. And what does that mean? Nationally, that was between 7 and 10%. So we are already three times over. And this came from our survey vendor who serves almost 85% of Medicare Advantage plans nationally. So that tells you the difference. And we are using that. Second, how do we gather these emails, right? That is the way our members want to engage. We use a multi-pronged approach. Not only do our sales team does a great job during enrollment, but we also have talk about human touch, right? Digital is complementing human-centric support. So it's not on its own. So we have care guides, talk about navigation. Care guides are these non-clinical people that Mass General Brigham offers to navigate through this maze of healthcare, right? Finding doctors, understanding benefits, and everything along with that. And last but not least, talk about that forward-thinking customer service I said. So customer service is a big, big driver. We have prioritized in our customer service even to gather those email addresses because apparently ours is, just like in many metropolitan areas, demographics that's more tech savvy. And to close the loop here, on our system, my chart, anybody who is in this area knows, is very well received and well used by membership. Our members are demanding that we combine my chart, especially if they're using Mass General providers, with our member portal. So this is a big bet for us. We are really investing. We know people like digital approaches. We get their news from there. Telemedicine, which is our benefit, well received, ordering your prescriptions. So we're hoping this engagement approach that we're seeing, already getting some results from CAPS, that we can drive our outcomes even using that. It's one of the ways to close the gaps in care.
All right, I'll summarize very quickly because I know we're just about the top of the hour. Create an organization that's focused on collecting your members' emails. It sounds simple, probably much more difficult to execute, and you could potentially have 30% of your CAPS responses come via email, like Mass General Brigham Health Plan. Also, when appropriate, if my chart is the way that everyone wants to engage, which is God bless Epic, right? Get it integrated into your portal. So those are the two big things I heard. Thank you all for all the work you guys did preparing for this show, all of our guests. Thank you all listening and watching right now, for tuning in. We do not take the hour you spend with us for granted, and we hope that you use the ideas, the bright spots shared today to inspire your thinking, enhance your company's approach to improving healthcare for all of us, like just collecting emails when they call in. Remember, we produce this show for all of you. This is your Bright Spots in Healthcare podcast. Take care, everyone.